Okay. So today we are going to talk about perinatal PTSD and trauma-informed care. I feel like I don't need to tell you that you have experience with perinatal, but you can see there is so much trauma in this population, and trauma is really prevalent and widespread all around us because it's not just our patients. Sometimes it's the healthcare professionals that have the history of trauma or that they are exposed to trauma and then are traumatized by that relationship. So I think it's so important to talk about this. So I will start with the definition of trauma. And this is the definition that SAMHSA gives that I think is the most complete one. And it says that individual trauma results from an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So I think it tells us a lot that trauma really can affect the person as a whole in so many levels. And one important thing that I want to say is that trauma can be, there are different kinds of trauma, like there's direct trauma, there is vicarious trauma when you live it through somebody else, But one thing I want to say is what happens when somebody perceives having an experience as traumatic, even if for you that you are interviewing that person, you think maybe that experience is not so traumatic. But the important thing is what the person feels, and how the person perceives the experience, because that will bring the consequences. So I wanted to mention that. There are 4 categories of symptoms associated to trauma and stress. So there are the intrusive symptoms that are basically intrusive thoughts, repeated memories, distressing dreams, flashbacks, nightmares. Then there is avoidance, and it can be avoiding of events, people, memories, places. So that reminds you of the trauma. Then there is alteration in cognition and mood. And then you can see inability to remember important aspects of the trauma, negative thoughts and feelings, leading to distorted beliefs about oneself or others, wrongly blaming self or others, and fear, anger, guilt, shame, less interested in things, feeling detached. So you have the idea. And then there is the alteration in arousal and reactivity, where you have sleep problems, having problems concentrating, easily startled, self-destructive behaviors, being reckless, irritable, anger outbursts. So all these symptoms together can manifest when somebody has a traumatic event and stress-related disorders. And then the DSM-5 classifies this as acute stress disorder if it's 3 days to 1 month. Post-traumatic stress disorder if it's more than 1 month after the trauma, and delayed onset if it's more than 6 months after the stressor. So the other thing I want to say is, and we'll talk more about PTSD, but it's so associated with different mental illness. It doesn't come alone, but it can be associated to substance abuse, to depression, anxiety, borderline personality disorders. So you have to look not just for trauma, but how that trauma is affecting that person and their whole mental health. So what's the prevalence of trauma and PTSD in the US? So the US National Comorbidity Survey shows that 60% of men and 51% of women reported exposure to at least one lifetime traumatic event. And it also found that 7.8% of the respondents had a lifetime history of PTSD. The reality is that the majority of people have exposure to trauma in their life, with some studies suggesting that it's up to 90%. And what we are going to focus on pregnancy, but one thing I want to say is that one form of trauma is intimate partner violence, and it's very common in pregnancy. So that's something to keep in mind. So there was an important study in the 90s done by Kaiser Permanente, and they looked at adverse childhood experiences. And they saw that there is a strong dose-dependent relationship between one's exposure to abuse and dysfunction in childhood, as measured by this. They created a score, this ACE score, and risk factors for leading causes of death in adults. So this is very important because it tells you that it's not just in your mind having traumatic event, it can affect you as a whole, as what we said before in the definition of trauma. And it was the ACE score was calculated based on the number of yes responses on a 10-item survey regarding one's exposure to 3 domains of adverse experiences before the age of 18. And it was abuse, neglect, and household dysfunction. And they saw that people who had experienced 4 or more categories of childhood adverse experiences had a 4 to 12-fold increased risk of health risks like alcohol use, drug abuse, depression, suicidal attempt. They also had a 2 to 4-fold increased risk in smoking, poor self-rated health, having been promiscuous, having STDs, and 1.4 to 1.6-fold increase in physical inactivity and obesity. So the other thing that is very interesting about this is that they realize that only 10% of health outcomes may be attributed to actual medical care. And in contrast, 40 to 60% are attributed to social and behavioral factors, which is so important to keep in mind. So here you see like a pyramid with, from the beginning, like historical trauma, how it's passed by generations, then to the social conditions, and then the adverse childhood experiences, and how it goes up until we get disease, disability, social problems, and early death. So it's like the basis of early death and diseases are based also on adverse childhood experiences. So trauma affects perinatal outcomes. And here I wrote a list. I also like to show how, because people think, okay, I suffered this trauma, but I have to tolerate it in my mind, it won't affect my pregnancy. But there are clear effects of the trauma in perinatal outcomes. And here you see preterm delivery, low birth weight, NICU admission, cesarean delivery, suicidality, depression and anxiety, poor bonding, substance abuse, fetal death, unintended pregnancy, and poor child health and developmental outcomes. And we'll talk more about these things when we talk about PTSD. And in women with history of adverse childhood experiences and past trauma, there is an association. They are more prone to have substance abuse, suicidal attempts, adolescent pregnancies, and a lot of medical comorbidities. So perinatal post-traumatic stress disorder, it is found in women who had a previous complicated delivery. Usually it's women that experience the complicated delivery, like with a sense of control, intense pain, not being heard, and that can predispose them to PTSD. And it can affect the woman's future childbearing decisions, abilities to breastfeed, and relationship between mother and infant. And we'll talk more about that. So it's more and more recognized in, perinatal post-traumatic stress disorder. It's usually described more after a traumatic birth than during pregnancy. As I said, it's associated with intense pain, sense of loss of control, and feeling powerless during labor. And there is a lot of literature about the psychological reactions to pregnancy and infant loss, but there are inconsistencies when looking at parental reactions associated specifically to the type of loss. And they see that there are some psychological reactions to perinatal loss as a whole. And they saw that there is a prevalence of 25% of PTSD 1 month after the pregnancy loss. There is anxiety, there is depression, loneliness, isolation, dissociative experiences, and somatic symptoms. So how the traumatic event affect the relationship between mother and the child, sometimes it leads to avoidance of the baby. It also, in the literature, is described how women with PTSD might decide to get sterilized, they can't have a sexual partner. There is also history of women that request of terminating an unplanned pregnancy. And some women may avoid contact with their kids for many years. And some avoid relating to other mothers and children, increasing their isolation. And the other thing that we see is that women with sexual abuse may re-experience abuse during childbirth procedures or during internal examinations. I had a patient who was abused as a child, and for her, she did well during pregnancy, during the delivery, but was very triggering was breastfeeding. And when the baby was breastfeeding, she used to have flashbacks of her abuser touching her breasts. So it can be re-triggering of a past trauma, all the experience of pregnancy, postpartum, breastfeeding, and labor and delivery. So what's the real prevalence of it, And really, we are still learning about this, but there is a recent systematic review and meta-analysis, and they saw a prevalence of 3.3% during pregnancy and 4% of postpartum PTSD, but mostly in relation to a traumatic event during birth. And then in high-risk samples, when you go and you look like maybe in a psychiatric clinic or a high-risk clinic, you will see that women who have severe complications in pregnancy or during childbirth, the rates of the prevalence are higher to 15 to 18% after a premature birth, after emergency C-section, or after stillbirth. But it feels like studies underestimate the total prevalence of PTSD in the postpartum period, because the studies so far only examine PTSD related to traumatic childbirth experiences. So what happened in healthcare? And I guess this is something that I don't need to tell you because you're very in tune with your patients, but there is a lot of trauma in healthcare, and past trauma is associated with poor interpersonal relationships and trust in people and systems that may be important for the person's well-being, which means that supposedly the healthcare system is there to help the woman, but the woman might feel she doesn't trust the person that she's seeing, she doesn't trust the system, and she doesn't have the skills to relate in a way that will make it effective for her. It also brings re-experiencing of past trauma during physical examinations, as we said. And there is limited knowledge on healthcare systems on how to approach women with trauma history, and we'll talk more about that. There is lack of knowledge on how to recognize trauma and PTSD in OBGYN settings. So many times it goes unnoticed, and so patients might not disclose their trauma due to shame, helplessness, stigma, fear of partner retaliation, fear of CPS involvement, and providers do not inquire sometimes because of lack of training, insufficient time. They don't have the time. They say, oh my God, I'm going to open a Pandora box. And they might feel they don't know what to do with a woman after she disclosed her trauma and her symptoms. So what is trauma-informed care? Trauma-informed care acknowledges the need to understand a patient's life experiences in order to deliver effective care and has the potential to improve patient engagement, treatment adherence, health outcomes, and provider and staff wellness. And I'm sure we all have stories of patients that come to the healthcare environment and are faced with re-traumatization when something triggers them. And we will talk more about those cases when we finish with the presentation. What is important is to shift the paradigm, and not to ask the patient what's wrong with you, but more like what happened to you? What is your history, And I think that's very important. So trauma-informed care realizes the widespread impact of trauma and understanding potential paths for recovery. Recognize the signs and symptoms of trauma in individual clients, families, and staff. Very important, also on staff. Integrates knowledge about trauma into policies, procedures, and practices, and seeks actively not to re-traumatize the patient, but avoids creating an environment that inadvertently reminds patients of their traumatic experiences and causes them to experience emotional and biological stress. And I think we all saw this at some point, women that had a stillborn and have to come to the OB clinic to get checked. And there are all these pregnant patients sitting on the waiting area, or when they come in, the nurse asks them, "Oh, how far are you?" Or things like that can really be re-traumatizing for these patients. So in an organization, what do you need to be trauma informed? So you need to communicate about it. You need a transformation process. You need to really work on integrating trauma-informed care. And that needs a lot of communication. You need to engage patients in the organizational planning. This is very important, having patients on the board and giving you their feedbacks and telling you how you can help them is the best way of really being successful. You need to train clinical as well as non-clinical staff members, because everybody can re-traumatize a patient. Either the security guard, it can be the front desk, anyone that says something or treats the woman in a way that she feels triggered, that can re-traumatize. Creating a safe environment and preventing secondary trauma stress in staff. And we can talk about that, but we see a lot, the staff is exposed to a lot of trauma by hearing it from patients and sometimes living it with them during labor and delivery. So it's very important to take care of the staff. So as I said, it's very important to involve patients in the treatment process, and not just in the decisions of the organizations, but also in their treatment process. Like, you really need to give them the tools and that they should be in charge of their treatment. They should feel that they are in control, that you are helping them to get to the goal of having their baby, but they are in control of their treatment. You need to screen for trauma, training staff, as we just said, and having good referral sources, and partnering with other organizations. So what is the ACOG saying? So ACOG is saying that we need to screen for trauma, PTSD, and intimate partner violence in pregnancy. In reality, any patient that comes to OBGYN, it doesn't have to be a pregnant patient or postpartum. Any patient that comes needs to be screened. And you have the Adverse Childhood Experiences 10-item self-report scale. That is very important because it will give you an idea of what you are dealing with and how to help, what else to ask the patient and how to help them. And then there are some PTSD screening that you can use, like the primary care PTSD screen for the DSM-5, that is a 5-item screen that is used to use in primary care. I was looking, I didn't find any particular PTSD screening that will be validated to use in pregnancy and postpartum, but the primary care PTSD screen you can use also for pregnant patients. And then there are the questionnaires for intimate partner violence. It's very important to screen for it, and there are different ones that I listed here. What I want to say, women are very concerned if they are still with a partner of retaliation from the partner, of getting the partner, if the partner realizes that they spoke about it with somebody else, that's very scary for them. What will be the consequences of it? And that's very important to keep in mind. So one important thing is, like, if somebody comes and they speak a different language, usually you need to get an interpreter. That is, you can't get somebody from the family because you're going to talk about very sensitive information. So it's very important to get somebody that is a professional to help with that. And we can talk more about how to deal with these patients that come and are going through domestic violence. So there are different trauma treatment approaches. There is prolonged exposure therapy that what it does, it gradually approaches the trauma-related memories, feelings, and situations. And they learn that their memories or their triggers are not dangerous and do not need to be avoided. And what it does, you do it in 2 ways. You do it in session by the woman recording her trauma and then being able to listen to it with her own voice. And then also in vivo exposure. That what it means is that the therapist and the patient decide what will be good situations you do it in a grading level from the least traumatic to the most traumatic, but like, what are they avoiding? And then you try to help them to say, okay, from like homework, if you're avoiding the grocery store, you're going to go to the grocery store, and keep an eye on how they are feeling. And you teach them also techniques like breathing techniques and grounding techniques so they can learn what to do if they get very anxious in the moment or very triggered. Then we have eye movement desensitization and reprocessing. It's a therapy that focuses on the trauma memory while at the same time experiencing a stimulation, a bilateral stimulation. Typically is the eye movement. And this leads to a reduction of the vividness and emotions associated with the trauma memories. And I don't know if anyone here has experience with EMDR, but I find it so helpful for patients. They first do an inventory of all the traumas, and then they start with the most triggering one, from the least triggering one to the most triggering one, and they go through the process, and it helps a lot. Seeking safety, it's a therapy that actually it's evidence-based, and it can be done individually, in group. It can be done by people that are not trained, just following a manual, and it can also be done by peers. And basically what it wants, it's directed to women with trauma and or substance abuse. And what it wants is really to develop skills and go through a series of topics that are in their manual, and seeing how you can accomplish coping skills and how you can deal with all these situations. Then there is child-parent psychotherapy, attachment, self-regulation, and competency. And the other one I found very interesting is a trauma-focused cognitive behavioral therapy, which is more directed for children, but and adolescents, but at the same time, it's directed to the parent that is not the abuser. So it helps the parent help the child go through the trauma. So I thought it was important because many of these pregnant patients will have children that might have been abused also. So what about medications? How do you treat PTSD? So the SSRIs are considered first-line treatment for anxiety disorders and PTSD during pregnancy. You always need to use what previously worked. You need to try to minimize switching medications during pregnancy. You need to try, I'm saying try because you'll do what is best for the patient, but you need to try to keep them in one medication and the lowest effective dose. But this is very important. When I mean lowest effective dose, it means that it's effective, not just a low dose that it's not doing much. You will discourage the patient to stop their medication prior to delivery. There was an idea at some point. There is something called the adaptation syndrome that 15 to 30% of babies can get when they are exposed to antidepressants. When they are born, it's a transitory syndrome where they can have some symptoms like feeding problems, sleeping problems, being fussy, breathing fast. So, and that goes away, it's transitory. It used to be thought that if you stop the medication at the end of the pregnancy, you will be able to avoid that syndrome. But the reality is that's not the case. We don't know what makes it to happen, but we know that some babies seems to be genetically predisposed to it. So it doesn't make sense to stop the medication prior to delivery. Also because the time that the baby is born, when the woman is in the postpartum, is the time with most risk of postpartum depression and anxiety, and you really want to avoid that. And you might need to adjust the medications as the pregnancy progresses. And I'm always telling my patients this because they need to know that they might need higher doses as the pregnancy progresses. So what are the risks of antidepressants during pregnancy? There is a small but inconsistent increased risk of birth defects when taken in first trimester, particularly with paroxetine. If you read the well-done studies, you will see that the risk is not more than in the general population. So that's very reassuring. And most of the data does not suggest birth complications. And studies do not suggest long-term neurobehavioral effects on children. And what I said, there is this adaptation syndrome that is a transient neonatal symptoms that go away in not more than a week. And then you have to think about breastfeeding. In this woman with PTSD, you can also use the SSRI. There are first-line agents because they are non-sedating, they are well tolerated, and they are good if the woman is also depressed and anxious and has obsessive thoughts. It's really good for all of that. And sertraline and paroxetine are low or undetectable in the baby, which is good. Babies can have some negative adverse effects, but it's very unlikely. But you can see increased crying, decreased sleep, gastrointestinal distress, irritability. And there are small studies that report no long-term neurobehavioral effects, but we still need to see what's the risk in the long run. So in summary, trauma and PTSD are prevalent in the perinatal period. Trauma and PTSD can affect the perinatal outcomes. It's important to recognize and look for signs and symptoms of PTSD and a history of trauma. And a trauma-informed care in the healthcare setting will improve patient engagement, treatment adherence, health outcomes, and provider and staff wellness. So I wanted, we always try to talk about cases, but I have a case here, but we can talk about other cases if you want, if you have any cases or anyone that you want to bring up. Or I was thinking also to ask you how you're managing trauma in your organizations, in your places of work. How are you dealing with it? Because it's a big problem that we have. So I remember this case. I'm going to stop sharing my screen and then we can talk. Okay.
Trauma is a big issue that I run into a lot with probably every patient that I work with. I can just think, I'm just going to bring up a couple of cases, not most of the severe cases that I have, but a couple of the mothers that I work with have history of trauma, but have experienced birth trauma, probably related to their past trauma. But in just working with them and visiting with them postpartum, eventually we'll discuss their birth experiences being traumatic, and have had some luck with like somatic type therapies. We'll talk to me about seeing their physical therapist and getting like dry needling, and I just start bawling with dry needling, like they're getting their pelvic PT therapy, and that's fairly therapeutic for them. And my physical therapist will just let me, or just be with me and hold that space while I just cry, or have cried just with the stretching and release of that energy. And then one of them had also done, we have an equine therapist that moved to the area. And so she recently did the equine therapy and found that really beneficial for her also to move through her birth trauma. So that was just some good things. I also have utilized some peer support in that way with some of those women, asking their permission, of course. But I found that really helpful, because then I've noticed that those two women have bonded, and I haven't heard from them as much. Of course, I've checked on them per, what I'm doing with them with postpartum follow-ups, but they'd come in to visit with me quite frequently. And they've gone on walks together, they've visited, but I had asked, permission from each of them if they would mind visiting with each other. One of them had been further along in her process, had gone through that horse therapy actually, and was older than this younger woman. And they had really bonded. And so that was really beneficial. And I just thought I'd share that.
I think that's great, like all these different approaches.
Yeah, because it's difficult to find mental health, care access sometimes. So just leaning on some of the resources that, you do have in your grasp.
Yeah. The other thing I was thinking, is that when I was saying before that you have to give them the power, and the control over the situation, like doing a birth plan, like
Yes.
Even though sometimes it doesn't go as you wanted, but at least thinking about all the birth plan and having some say in what's going to happen. I think it's also important.
Yeah, and actually this woman, the older woman, I set her up to visit with, and this was her idea too, but she had a home birth that she ended up having to go to the hospital and deliver. And so I had her meet with one of the nurses and we live in a rural area, so it is nice. But I had her meet with one of the nurses that was at her delivery and asked if she could just meet with her and sit down with her and they could have a cup of coffee together. And that was really, really therapeutic for her also, just to be with one of those nurses that was at her delivery and to sit down. And that nurse was just a perfect person too. That was just like, you were just so strong. And this is how I saw you. This is how you presented, and your strength was amazing, because she felt super weak and incompetent. And that's how she viewed herself. And just to have that outside perspective of someone that was in her birthing space tell her that was really beautiful to her, to see herself that way. And so those are ways in which she moved through that, which was really, really cool. So I just kind of
Yeah.
help facilitate some of those things for her in that way. Yeah.
That's great.
Yeah. And then
Yeah.
I had another woman too that I did help, who had past history of trauma before she gave birth, create a birth plan. And so when I'm giving my prenatal classes, I say that a birth plan can look like, it can look different for everyone, because in her birth plan, what she wanted to have in there was, I need, she was worried about access to snacks, because growing up, she didn't always have access to food. And that gave her a lot of anxiety. Can I ask for food when I need to? If I can't have access to food or snacks, I get really anxious. So we visited about that. Or can I have my clothes on underneath the gown? And so we wrote all those things into the birth plan. And so those were the things in the birth plan that she wanted. And, then delivering those things to the nurses and visiting about what was important to her, that the snacks were available to be asked for, and that those were already said and done, took a lot of stress off of her.
Yeah. That's good examples. Thank you, Chelsea. Mandy is saying that birth plans aren't about the plan. They are about collecting the information and learning about risks and benefits and advocating for yourself. And I help a lot of women making their birth plans. I agree. I totally agree. It's not just about saying what it's about advocating for yourself. I totally agree. And learning about the process. And Sarah is asking, are there any seeking safety led online groups for pregnant moms experiencing trauma? I don't know really, that's a great question. Any of you know of any groups that are seeking safety led by peer supports? Stephanie, are you there? She's not. Okay. That's something to find out. I think it's a good question, actually. Yes, that's a good point. Check out Postpartum Support International. And Joanna says PSI has a group. That's great. So the other thing I wanted to say is that it's not always that trauma manifests as PTSD, as what I said, and when you see a patient, she comes to you and you have to figure out what's going on with her. Like it happened to me a lot. And for example, in PRISM, we got a consult from a midwife to see a patient who just had the baby like a week ago. And the patient was extremely anxious with panic attacks, like couldn't tolerate her anxiety and couldn't relate to the baby. She described it like she felt like there was a curtain, that suddenly came. And so starting to talk to her and hearing what she was saying, I tried to ask more about that curtain. What do you mean that something came and like now you are detached? And she described that during the labor, somehow she started feeling totally detached in a fog, like something separating her from the others, and that her experience changed. And I realized that she started dissociating, and asking more and more questions. I realized that she had a really difficult childhood with a lot of trauma. And somehow this birth was triggering, it was making her re-experiencing her past trauma, but she wasn't even aware of it, So when I brought it up to her, she kind of like, it made sense. And she felt validated. And she felt like, okay, now we have something to work on, like now we are going to address the issue, because she was feeling, I'm a bad mother, I'm not connecting. Like she really was seeing the future as totally dark, like there's no way I can take care of this baby, why I don't feel anything, why I'm numb. And so I was thinking about that, how there are so many different ways that trauma can express, like a history of trauma can express in a woman. Like the case that I had there written was a woman that came to me when she was postpartum and she couldn't talk almost. She had like severe psychomotor retardation. She was flat, affect. I wasn't sure what was going on. She couldn't tell me much, but I felt maybe she was psychotic. I wasn't sure, you know? And then she came several times. It was clear she was depressed. So we gave her medication for depression. She came several times. One time she came and they were doing a research study and they asked her to fill a form. And the form was asking how many children you have. And that triggered her. And she came to my office and she started crying and telling me how she was supposed to have twins. This pregnancy was of twins, but the first one died in utero in the second trimester. And all the pregnancy, they told her they didn't know if the other one was going to survive. So it wasn't just about the loss of the twin, but also about not knowing if her baby will survive. So the pregnancy was very traumatic. And that's how she expressed how she exhibited her symptoms. You know, she came like very, very detached and flat, you know, and it was clear she was dissociating. So I think it's important to keep in mind that it's so prevalent and it has so many ways of expressing in different people. What I wanted to ask you is like, because the other thing that I think it's so important is as staff or as providers, how we get traumatized by the experiences, you know? And even if we have a lot of years of experience, we still are confronted to situations that are very, very traumatic and that can traumatize us, you know? So I was wondering how your institutions, or what are your thoughts about how to deal with that, with the professionals that are treating the patients and get traumatized by the experience?
We recently had a provider with a fetal demise with a labor that kind of went wrong. So just, I mean, heartbreaking, right? It's like the worst that any delivering provider can experience. And I think there's support and a non-judgmental group of, you know, support staff, and that they're talking about it. I would be worried if they weren't talking about it and able to, but it, you know, and then just acknowledging that it's the worst thing that could ever happen to you. And, you know, if you need to talk about it, we're here, you know, let us know if you're not sleeping, you know, all this stuff. Just, but I think I would be worried if they weren't talking about it, like pretending everything was normal. So that they're talking about it is reassuring, but checking in frequently, because they did have subsequent deliveries that have gone fine, but definitely acknowledging that there's that weight and the worry that it could repeat itself. So
yeah, that's good, you know, like I think, yeah, talking, it's so important, you know. And I remember when I was working in the hospital, I lost a patient to suicide, a postpartum patient, and that was devastating. And the hospital, they had a team that came to me and first let me talk, let me cry, and let me take my time, you know. Like, I think it was so important because you need that space. You need that space to deal with the trauma that you are exposed to. Any questions, any thoughts?
I do have a question. Hi. So yes, I'm working on universal screening for birth trauma, specific to trauma that could happen like from birth in the perinatal period. So the tool that I have been looking at the most is the City Birth Trauma Scale, which covers the DSM PTSD criterion, but for birth specific. My question for you, it is validated and have you heard of it? It's been reviewed.
No.
It's pretty recent, 2018.
Okay.
What's cool about it is that it is birth specific for PTSD.
Yeah. Yeah.
But my question for you is that when I'm implementing the tool, I currently, just for like a process, the first two questions are, do you believe you or your baby would be seriously injured? And then the second question is, did you believe you or your baby would die? So those are the questions that I'm planning on having a universal screening inpatient, and then at the 2-week postpartum visit alongside the Edinburgh Depression Scale. I guess previously I was thinking if they answer no to those two questions, they don't need to fill out the rest of the screening tool that goes more into the dissociative symptoms, bad nightmares, flashbacks. It goes a little bit into bonding with the baby and whatnot, but kind of like your story with, I'm wondering if that does, if, I don't know, if that those two questions don't capture all the trauma that they could experience. Does that make sense?
Yeah, that's what I was thinking when you were talking, is that there is so much other trauma, but
Right.
It depends what you're focusing on. If you're focusing on the birth trauma, maybe that's enough, but you also want to capture trauma during pregnancy, like obstetrical complications or losing a twin or, all that other stuff you might need to be a little bit more broad,
Okay, yeah.
or add questions.
That does help. I do think that, yeah, if they fill out the rest of the screening tool, that would cover. Yeah, okay, that's helpful. Thank you.
You're welcome.
I just had a question about like prolonged exposure therapy or trauma focused therapies. And maybe it probably just hasn't been studied, but just thinking about the risks of that, if this is someone who's pregnant, if they are, right? I just think about like all the cortisol and stress and, and I was thinking about a case who, she had, gosh, how old was she? 36, mother of 5, but her most recent child died from SIDS like 2 months after delivery. And was definitely my criteria for PTSD, and became pregnant without having resolution of symptoms before this subsequent pregnancy, and had hypertension as well. So it was this complex discussion of, do we do prolonged exposure? She was very against use of medications for treatment of symptoms, again, because she was worried about risks to the baby. But it just generated an interesting discussion of like, what would the risks of a prolonged exposure therapy be in that case?
I agree. I think, you need to be very careful because of all the physiological reaction that you can create with exposure. But I think if you can do it in a graded way, and start with the least traumatic to the most, and maybe not get to the most traumatic during pregnancy, but we have that discussion all the time, like when do you do it and when not, and when it can be detrimental to the pregnancy.
I like that idea of like, could we do it in a gradated fashion and then just be checking closely with like MFM or OB or vitals.
Yeah. Now that's a good question. And Sina is saying, I would strongly encourage a community provider to team up with to provide the most support for the new mom and this new relationship. Makes sense. Yeah, totally. So thank you for being here. Any other questions or?
Thank you so much.
Thank you. It was really, I love the discussions after the presentation. I think they are so helpful, and everyone has so many good things, so many important things to say. So I'll see you next month. I think next month we will be talking about infertility. So That will be interesting.
Thank you.
Thank you.
Okay, thank you. Thank you for being here.